Hi, everyone. Welcome to our workshop on the topic of how to be prepared for the 5 types of births. My name is Ananda, and I am the director of Boston Doula Circle. We provide birth and postpartum doula services and a variety of other offerings in the greater Boston area, along with our workshop series, which you're attending right now and which is available to people in any location. Thank you for being here. I'm the co-author of The Doula Guide to Birth, which is a book published by Penguin Random House. And I was trained as a childbirth instructor under the auspices of the Lamaze International Organization. And I'm so happy to be here with you today. I would also like to invite my colleague, Carrie, who will be my co-instructor today. I'd like to invite Carrie to introduce herself.
Hi, everyone. My name is Carrie Babish, and I am a full spectrum doula. I do birth and postpartum support with Boston Doula Circle, as well as being a lactation specialist on the team. I'm also a mom of 3 and a former school teacher. So I love being able to offer these educational experiences, these instructional experiences tied into our birth work. And I hope that you all get a lot out of it today.
Thank you. I just want to say a word about how we're going to conduct the workshop today. Everyone who is watching live is going to be muted, except for myself and Carrie. And what we'd like you to do is put any questions or comments that you have into the chat box here on Zoom, and we will do our best to answer as many of your questions as we can. And if we're not able to answer a question right away, I'll be available to stay on the line for a few minutes after the official workshop ends so that we can discuss any remaining questions that you have. And I'd like to say that today's workshop is going to be helpful to you if this is the only childbirth class that you're able to take, and if you are taking other childbirth classes or you're taking other workshops with us here at Boston Doula Circle, you will be able to use today's information in conjunction with those other classes. So for today's class, we have organized the different ways that childbirth can unfold into 5 categories. There are more than 5 types of births, but everyone has an experience that fits into one of these broad categories. And sometimes your birth will fit into a few of these categories. So let's take a look at what those are. Okay, so we've categorized the 5 types of births as type number 1 is vaginal birth that is unmedicated. Birth number 2 is vaginal birth with an epidural. Number 3 is labor that starts spontaneously on its own. Number 4 is labor that starts by medical induction. And number 5 is birth by cesarean section. What's interesting about these 5 types of births is that they're not really interchangeable. For example, an unmedicated birth is not the same as a birth with an epidural, with the only difference being that you feel all of the sensations in one birth, but not the other. Each of the 5 types of births has specific characteristics, and each type of birth has its own unique benefits and risks. And it's important to be informed about what these differences are so that you can maximize your chances of having the type of birth that you hope for. And we also want you to be prepared to respond to any birth scenario in case you might unexpectedly encounter a type of birth that you were not planning on. And in that case, how can you still preserve what is most important to you? So we are going to be talking about this, and that's the approach that we're going to be taking. So I'm going to start out with birth number one, which is vaginal birth that's unmedicated. And I'd like to talk about, give you a description of what this looks like and feels like. And we'll be doing that with each of the types of birth. We're going to talk about some of the details of this particular scenario that you can expect to potentially feel. And then we're going to talk about the benefits of this type of birth and the risks of this type of birth, and we'll do that with each of the 5 types of births. So what I'd like to say about vaginal birth that is unmedicated is that people usually describe the beginning of labor as not being painful. They usually describe that they feel a tightening sensation in their uterus and in their abdomen, and it comes and goes for a while, but they wouldn't necessarily describe that as painful. So if some of you are currently pregnant and in the later part of your pregnancy, you may have started detecting what are called Braxton Hicks contractions. Those are warm-up contractions. That's the way in which your uterus exercises itself throughout pregnancy. And those type of contractions, these warm-up or practice contractions, they actually start in the first trimester of pregnancy, but we don't ever really hear anyone reporting that they feel and can identify their Braxton Hicks contractions in the first trimester of pregnancy. Sometimes we hear people describing them in the second trimester, but most commonly people describe them later in pregnancy. Might even be the last 1 or 2 weeks of the pregnancy when they finally kind of figure out that they can identify that tightening of the abdomen. And if that's something that you've experienced, that does give you a preview of what the beginning of real labor will feel like. It's a very similar mechanism that that the uterus tightens itself. And I always thought it would be great if every muscle in our bodies could exercise themselves on their own. But as far as I know, the uterus is the only one or one of the only muscles that exercises itself. But again, that gives you a preview. If you've identified your Braxton Hicks contractions, that is similar to what the beginning of labor feels like. And for some people describe as the hours of labor go on and go by, there is an intensifying of those sensations. And some people describe it by saying it starts to feel like menstrual cramps to them. And everyone has a different experience of menstrual cramps. So for some people, that might be what I would call like a muscular aching sensation. Other people have menstrual cramps, which feels sharper and a bit stronger. So we can use the analogy of menstrual cramps, but just keep in mind that if someone said, labor started to feel like I was having my period, that actually might be a little different for different people, but it is a description that we hear folks use. And there's a classic description that childbirth instructors like myself have used for many years, and that is to say that the contractions of labor become longer, stronger, and closer together as the hours of labor pass. It's a very simple description, but it has held the test of time, and it is a great way to think about it. So at first, that squeezing sensation of the abdomen might be fairly brief, but you realize, hey, that's happening, every 8 to 10 minutes, and it's coming back. It's starting to form a pattern, and it's not going away. They later in labor, those shorter sensations that you had in the beginning, which might last 15 to 30 seconds, will become longer. So that's the first component of that phrase: longer, stronger, and closer together. The sensations will become stronger, and they almost always become closer together. So could start out again 8 to 10 minutes apart, and over time we're going to see those get closer together, and they're going to come all the way down to being 2 to 3 minutes apart when we get near the end of labor. As those sensations intensify, we do hear people use the description that they can become painful. Many people have reported that, although there are a few people who have used other words to describe the sensations of labor, words other than pain. Some people have said it was very hard work, and probably the hardest work that they'd ever done. But some people have described their labors without using the word pain. But of course, many of us have heard the description that they can become painful. If someone has had some kind of a previous pelvic pain condition, such as endometriosis, when they were not pregnant, that person might also have a preview of what labor can feel like as it becomes more intense. And I once taught a childbirth class, and there was a father-to-be who asked a question, raised his hand, and said, would you describe this cramping sensation as being similar to having a Charlie horse? And I thought that was a terrific description from this person who did not have a uterus. And he made the comparison to a Charlie horse. And I said, you know what, we could go ahead and include that, meaning we've got a muscle that involuntarily contracts itself. And the difference I will make between a Charlie horse and a labor contraction is that Charlie horse, I believe, tends to come on really suddenly at full strength. That's a cramp in the leg, is a Charlie horse. And the contractions of labor actually take more of a pattern of a wave, where they start out with a noticeable sensation. That sensation builds up over the course of, let's say, 1 minute, and it reaches a peak, which is quite strong. And that peak might last for as long as it takes you to take 1 or 2 breaths, and then the peak will start to decline again, and it'll subside and go away. So I think of that as being a bit different from a Charlie horse, that a labor contraction comes on, and during the course of one contraction, will reach a peak and come back down. And that's a strategy that can actually be used for managing labor and coping with labor, is to notice how the sensations change from moment to moment. That's a mindfulness technique. So we love to use mindfulness at Boston Doula Circle, and a person can notice, like, okay, I feel it coming. It's not starting out at its strongest intensity, but as a few more moments pass, it is getting stronger. I'm going to use my breath and take some deep breaths and count that it's just going to take me 1 or 2 deep breaths to get through the peak, which is the strongest sensation and might be the most challenging to cope with. And then it's going to subside, and I'm going to get to the other side of that. I also want to mention something that we don't hear as frequently, but People have sometimes reported having a sexual response in labor, which is really, really interesting. And this has been researched and studied. It can occur in a couple of ways. One is that some people have reported simply having this spontaneous sensation. There's a few reports out there of people having an orgasm spontaneously in labor, which is pretty amazing. And this is due to the fact that all of the same organs of lovemaking are involved in the act of childbirth. So we've heard a few reports of this happening spontaneously, but we also hear it when people have chosen to incorporate some kind of sexual activity or intimacy into their labor as a comfort measure. And again, we might not hear those stories very, very often, but it's a wonderful technique that can be used when you're in the privacy of your own home. You can cuddle with a partner. You can lie down and naked with a partner. You can use sexual activity by yourself. You can have intercourse. You can really use just about any any of the activities that fall under the range of physical intimacy or sexual activity. And one of the studies that was done on this topic a few years ago came out of Europe, and it was reported upon, and I believe that Carrie dropped a link into our chat box to if you'd like to check out this article that was reporting on the research. And the article is called "Can Women Orgasm During Childbirth?" So it's very, very fascinating, and feel free to take a look at that. And we mention that because we do tend to hear labor and birth described in terms of pain, and there can be such a wide range of sensations reported even by one person. One person can report many different sensations that come up in labor, and they don't have to just be scary or painful. People have actually reported pleasurable sensations. And I'm thinking of actually a neighbor of mine who lives about 1 block from my house here in the Boston area, and she describes having had an orgasmic birth. As labor progresses and it reaches its strongest intensity, many people would say it is the greatest physical and emotional challenge that they have ever voluntarily undertaken. And at the same time, it is an event that you can do, you can handle it. It has been done for hundreds of thousands of years. And so both of those things are true at the same time. It's helpful. I think it's helpful to face the reality that it's a tremendous challenge, and you can do it if that's your choice. If your goal is to have an unmedicated birth, your chances of achieving this in a hospital are more likely if you utilize the support of a doula. And simply as a side effect of having a doula present to provide labor support, the use of epidurals goes down. Studies show us anywhere from 25% to 60% reduction in the use of epidurals. So that's something to keep in mind. And doulas can really be available to anybody. I know here in the Boston area, we have a large and thriving doula community, and there is a doula for every family and every budget. There are not everyone realizes that they can find a doula. And there are even doulas available on a pro bono basis if the family were to have that financial need. So we're just posting in our chat box a link to the website doulamatch.net, which is an excellent resource for locating a doula near you. And I'll mention just one more. I'll mention one more sensation that somebody might experience with an unmedicated vaginal birth is that during labor, as your body is working hard, your body's releasing endorphins, which are the natural pain-killing chemicals that our bodies can produce. And after an unmedicated birth, our endorphin levels are the highest that they'll ever be in our lifetimes. So they're about 30 times higher, endorphin levels, immediately after an unmedicated birth than they are at any other time, for 30 times higher than they are for a non-pregnant person. Some people report feeling a sense of euphoria once they've given birth, because they're left with this very high level of endorphins, and some people have described it as feeling like a high. And this is not the case when an epidural is used, because the epidural counteracts the release of these various chemicals. And so it's still a very great thrill to meet your baby with an epidural or with an unmedicated birth. We just don't get that. We get the bonus of the extra high levels of endorphins with an unmedicated birth. So I'm gonna pause here and turn it over to Carrie.
So just as we are going to describe for you for each of the types of birth, what it looks and feels like for people, we also want to explain some of the benefits and reasons why a person might choose to have that type of birth. So with unmedicated birth, one benefit or one reason that somebody might choose that type of birth is there is no chance of side effects from drugs or medication because they're not being used. Some people just generally in their lives have a preference to avoid extra medications that are not essential. And for others, there is concern about what side effects might be involved. So that is not a concern with unmedicated birth. And occasionally we have folks who have to avoid epidural because of other conditions or other medications that they take, in which case unmedicated birth becomes even more important. Some people choose to have an unmedicated birth because they want the sense of meeting an important personal challenge, such as folks who choose to climb a mountain or run a marathon. For some folks, that's the reason that they are choosing unmedicated birth. For others, this is a big part of the reason why I myself chose unmedicated birth, and I've heard other folks report the same reasoning, is that it increases your ability to move throughout the course of your labor. When you choose an epidural, and we'll talk a bit more about this later, your movement is more restricted. So for folks who are looking for the ability to keep moving during labor, unmedicated birth is going to give you the greatest range of motion. We also see another benefit of unmedicated birth is that the research shows us that breastfeeding is more likely to get off to a smooth start and therefore be successful when unmedicated birth is the mode with which baby arrives. It's also the type of birth that is least likely to lead to a cesarean, although this is not a guarantee, but it definitely decreases your chances of a cesarean birth. And some people choose this type of birth because it is the norm in their culture, particularly in other parts of the world that don't have necessarily the same medical infrastructure or certain types of religious or cultural backgrounds. So this is something that's true of all the types of birth that we'll talk about. What we do is often shaped by what is the norm of our culture or our subculture. We see lots of people who actively choose to go against the norms of their culture, but they're called norms for a reason. Most of us are definitely shaped by them. We also want to address for each of these types of birth the risks and side effects of them. So for unmedicated birth, we know that unmedicated birth is possible for the majority of people, but there are a few situations where it truly is not possible. If someone hopes for an unmedicated birth and the plans have to change, sometimes people have reported feeling deeply disappointed or even traumatized. The traumatic response may be more of a risk if someone had no preparation for unexpected scenarios. And that's why we're here today, to be more prepared for all possibilities. We do find that when people have spent some time thinking about how they might respond to an unexpected birth scenario, it helps them to be ready to face it. So with any vaginal birth, another risk is the possibility of strain or injury to the pelvic floor. So this is true with or without an epidural during the pushing phase of labor. This might be preventable with less forceful pushing techniques. However, most doctors and nurses are not trained in gentle pushing techniques. A doula can be very helpful with these. You can also learn them through certain childbirth education. It is something that you sometimes need to advocate a bit for in a hospital setting. If strain to the pelvic floor does occur, it's usually very treatable with the help of a pelvic floor physical therapist.
Thank you. And we're going to move on right now to type of birth number 2, which is a vaginal birth with an epidural. And I'll start out by describing what that looks and feels like, just like we did with the first type of birth. So contractions are felt until the point in labor where a person decides to request an epidural. So there's going to be some overlap. Anyone who is experiencing labor is going to feel contractions at least some of the time. And if an epidural will be used, then those contractions will be felt up until the epidural is put into place. With an epidural that is working correctly, 2 things will happen. One is that the person will be free of the sensation of contractions once the epidural is administered. And at the same time, the second thing that will happen with a properly working epidural is that the person will be able to retain some of their motor ability. So Carrie mentioned earlier that there can be more limitations on moving around when an epidural is used. However, the person should be able to retain some of their ability to move around. The heavier the dosage of medication in the epidural, the less motor ability a person would have. So there's a direct correlation. If an epidural is created using a heavy dose of medication, that is going to result in less mobility. And however, again, there is research showing that when epidurals are created using a lower dose of medication, pregnant people report satisfactory pain relief. So we're really looking for those 2 things to happen. If we're making use of an epidural, we're looking for the removal of the sensations, and we're looking for the ability to retain some mobility. We want both of those things, not just one or the other. So if someone were to find they're using an epidural and they're not able to move their legs, that would be a time to talk with your doctor and care providers and report that, because any epidural can be adjusted in its dosage. Occasionally, an epidural needs to be replaced, and it can be worthwhile if the dosage is so heavy that a person cannot move their legs and they're fully immobilized. We want to make use of the benefits of still having some mobility in labor. Another thing which is characteristic of birth with an epidural in the United States is that doctors and hospitals will prohibit the person in labor from eating solid foods beyond the time that the epidural is placed. So that could last for a few hours, or it could last for more than an entire day. That solid food is prohibited, and there's actually debate around this topic. Here in the US, we may have the strictest guidelines about that. There's other parts of the world where that's not the approach at all. But that's something to keep in mind, is that that's still a pretty strong tradition here in the US, is to ask the pregnant person not to eat after receiving an epidural. And then one other thing that might happen in terms of what the situation looks like, is that the person in labor might receive less labor support from their loved ones, from the hospital staff, because now there's technology involved, and people are going to be paying quite a bit of attention to the technology, machines that are recording how the labor is affected by the epidural. And sometimes everyone really gets focused on looking at the technology and the monitors. And that's just something to keep in mind, because we can still actually provide lots of support to the person in labor. We just need to keep that in mind. We can turn off, beeping noises on machines. We don't necessarily need to hear every sound that's being transmitted through machinery. We can still incorporate things such as massage, which is a support technique that doulas and partners will often use during an unmedicated birth. We can do the same thing if medication is being used, and really nurture that person who is still in labor, even with an epidural. We can use things such as meditation, prayer, affirmations. You can listen to music and use other comfort measures. So just wanted to mention that, again, when we think about what it looks like, what it looks and feels like, is sometimes there is a shift over to the technology, and we can keep that in mind so that we can stay focused on the person who is actually giving birth. And I'll turn it over to Carrie.
So we are going to chat now about the benefits and the reasons that folks choose an epidural. Obviously, the main reason that people do choose to get an epidural is related to those reports that Ananda mentioned that people give of the pain of labor. So sometimes we see that people make a plan for an epidural. They know that they're going to want an epidural during labor because they have heard those reports, and they do not want to experience that intensity of sensation. They prefer not to experience the potential pain of labor, which is very reasonable. Some people do not necessarily plan to use an epidural, but those sensations reach a point where they decide that that's the best choice for them during labor. Interestingly, though, the most common reason we see people choose epidurals when it's not part of their initial plan is because they have become sleep deprived during labor, and not because they can't handle the hard work of labor. So people are able to sleep generally pretty well after they receive an epidural, catch up on that rest. We do want people to know that it is possible to sleep during a long labor, either with or without an epidural. And the most likely way to achieve that rest, if you are wishing to stay unmedicated, is with the help of a doula. Another reason that people often choose an epidural is if there is a medical induction of labor. Contractions often feel even stronger than in a natural labor, and this can lead to epidural use. A unmedicated birth is still possible. Some people do continue along to have an unmedicated induced birth, but it is not as common. And when we talk about those contractions feeling stronger than natural labor, sometimes this is because they actually do get stronger faster than with spontaneous labor. As Ananda mentioned, early labor tends to be quite gradual in a spontaneous labor. It builds up over time. Sometimes with an induced labor, things can be quite slow, and suddenly very intense without as much of that buildup. Sometimes the contractions feel stronger. They may not physically be stronger, but they feel stronger because of those endorphins that we talked about. When there's an induction of labor, they use an artificial hormone called Pitocin, which is a copy of the hormone oxytocin, which our bodies produce naturally. And when the body starts to receive Pitocin, it stops producing as much of its own oxytocin, and that affects the biofeedback loop that produces endorphins in labor. So those contractions may be the same strength physically, but your experience of them can be much more intense without those endorphins buffering it. And that's one of the reasons people often choose an epidural during an induced labor. And many, many people choose an epidural because it's expected in their culture. Again, as we talked about before, cultural norms are a big part of what shapes people's choices. And we know that particularly in kind of mainstream American culture, epidurals are the norm. So that can be a really big part of what makes somebody choose that type of a birth experience. And I'm going to pass it back to Nanda to talk a bit about the risks of an epidural.
Hey, thank you. The most common side effect or risk of an epidural is that pain relief is not entirely successful. So if someone were to make use of an epidural and you were to discover that you're not experiencing the pain relief you were expecting, you're not experiencing the removal of the sensations, then speak up as soon as you can to your care providers. And you may need to speak up more than once, but that's something to advocate for. And again, that there are a variety of ways in which an anesthesiologist, which is the type of doctor that administers an epidural, there are various ways that they correct this. And so we encourage you to have a conversation, ask for information. How will you correct this? Because there's different techniques, and you can be informed about what is being done to correct the issue. I'm also going to mention something. As I was listening to Carrie, I realized that we're going to have another workshop coming up. It's going to be held in June. So if you're still pregnant in June, you're welcome to come back and join us again. And we're going to be talking specifically about the topic of facing pain in labor with or without an epidural. And we're going to go into a lot more detail about how people can make decisions that are best for them about using pain relief. So we're going to spend an entire workshop just on that topic. We'll be letting you know if you signed up here. We'll get in touch with you again to potentially join us for that next workshop as well. Another side effect potentially of an epidural is that there can be a drop in blood pressure for the pregnant person. This affects, my understanding, this affects, or this side effect is present with about 1 in 3 epidurals. If the person's blood pressure goes down, that can lead to a drop in blood flow to the baby and what we call a non-reassuring fetal heart rate, which is also known by the term fetal distress. This is usually treatable, but it can be a moment during birth that is challenging for people to, when there is concern that the drop in blood pressure for the birthing person is affecting the baby, And that is, like I said, it's usually treatable, but I think it's also important to know that it can happen with 1 in 3 um, epidurals. And then the last potential side effect that I will mention, and I'll say with any type of medication or medical technology, side effects are possible. So there's no medication on earth that is free of any side effects whatsoever. And that's true for technology that's used during childbirth. So we don't even really mean to single out the technology that's used during childbirth to say, like, gosh, it's risky. Most people are able to use it successfully, but side effects are possible because there is no medication of any type that is free of side effects. There may be an increased chance of birth with an epidural leading to cesarean birth. And there have been multiple studies on this topic. People have come to different conclusions. I like to refer to a research project called the Listening to Mothers studies, which are a series of surveys that have been conducted nationwide, and this research is conducted here in my area at Boston University. It's been going on for a couple decades now, and they periodically, as part of this research study, will interview large numbers of families at random across the United States about what actually happened during their births. And they have found that their studies have found that there appears to be a bit of an increase in the chance of cesarean section when an epidural is used. And we have heard many people say that they plan to make use of an epidural, but at the same time, they really prefer not to have a cesarean. So that's a very common wish or plan that people have. And because of that, it is important to talk about how to implement cesarean prevention when an epidural is used. If in fact there might be some chance of an increase, then let's talk about cesarean prevention in this scenario. The most common reason that a cesarean is recommended is a diagnosis that is known as labor dystocia, and that simply means slow. And this was the most recent report I was able to locate, was published in 2019 from the American College of OBGYNs, which is the major organization for obstetricians in the United States. And that's remained consistent over the years before that as well. But in 2019, ACOG reported that the most common reason that a cesarean is recommended is a labor that's simply slower than average. And why might a labor slow down? One of the reasons is that after receiving an epidural, there's an expectation that the pregnant person will remain lying down. However, lying down in itself makes contractions weaker, and therefore lying down can slow down labor. So I'd like to read to you from a page in the book that I wrote, The Doula Guide to Birth. And there's a little factlet here, factlet or factoid, that I want to share with you about using gravity in labor. The strength of a contraction is rated in units known as millimeters of mercury. And this is a way of measuring the amount of tension in a muscle. When the uterus is resting in between contractions, the tension in the muscle of the uterus is less than 15 millimeters of mercury. So if we were to measure the strength of a contraction, or the strength of the tension in the uterus, In between contractions, in its resting state, we get the number 15 millimeters of mercury. And contractions increase that tension. Contractions pull the muscle fibers into a tighter formation. That's the definition of a contraction of any type of muscle. And so contractions that are strong enough to dilate the cervix, to open up the opening, to dilate the opening of the uterus so that the baby can come out, they need to be 30 to 50 millimeters of mercury above the uterus at rest. And the strength of contractions increases by 35 millimeters of mercury simply by the mother or the birthing person being upright. So if we keep someone laying down, we're decreasing that contraction strength potentially by exactly the amount of tension that we need in order to keep labor going.
Ananda, there was a question
Yes.
of how much of an increase, according to the research, there is in the chances of a cesarean with an epidural. I don't know if you know that off the top of your head.
Sure. I'm gonna try to recall what the Listening to Mothers survey and studies found. But again, there have been multiple studies and different interpretations of them. What Listening to Mothers found was that when when birth was unmedicated, the chances of a cesarean section becoming necessary remained very, very low, in the range of probably like 0 to 5%. When an epidural was used, that raised the chances by about 10%. When actually, I'm sorry, by about 20%. And if an epidural was used along with the drug Pitocin, then the chances became 30%. So that's kind of a quick answer to a somewhat complicated question. So just going back to what happens when or why labor might slow down is another reason is that epidurals are they are associated with an increase in babies remaining in the posterior position in labor, which means that the baby's head is rotated so that the ideally the back of the baby's head will face the front of the mother's abdomen in labor. And I don't know if Carrie, if you have a doll nearby where you could possibly demonstrate that. So
the dolls are all downstairs.
So let's say, someone's abdomen is to the front of their body, and ideally we want the back of the baby's head and body to be in that space, but babies can rotate so that the baby's back is facing the back of the pregnant person's body. This was partly determined by a study conducted by Dr. Elise Lieberman at Brigham and Women's Hospital here in Boston. I was a part of Dr. Lieberman's study on another topic that she did, but it was really great that she was able to give us this information about what happens, what are babies doing during labor. And what she found was that the people in her study agreed that during their labors, they would receive that an ultrasound image would be performed on their babies in labor at 4 different points in labor. And this may have been the first time that we took a look at what so many babies were doing in labor. There were probably about 1,500 people enrolled in this study. And what the researchers found was that babies are swiveling around throughout all of labor. They don't just get into one position and stay there. They're trying to find the path of least resistance. And the path of least resistance would be baby's back facing the pregnant person's front. However, babies can swivel around so that their back is facing the pregnant person's back. That is a position that makes it a little harder for babies to come out. vaginally, and they can stay in that position a bit longer, so labor can become slower. And with an epidural, there is an increase in babies remaining in that posterior position, kind of trying to swivel their way around to the front, and that's part of what can take a bit longer. So just to return to the idea of laying down with an epidural, even though that's what tends to be what's expected, it's not required for any safety reasons. And it might not actually be a good idea for the reasons we just discussed to stay horizontal the entire time that an epidural is being used. And so I'd like to show you a picture of a family that we worked with at Boston Doula Circle. And this family, oops. Hang on a second. Let me go back to that. I wanted to show you the family of the person in labor who was sitting upright in a hospital bed. And
We could see that image.
I know, and then it's okay, here we go. All right, so this is a family that we supported at Boston Doula Circle. They gave us permission to use their photograph, and the woman who's giving birth, she's making use of an epidural in this picture. This picture, I took this picture after she had been making use of the epidural for about 12 hours. So a pretty long period of time with the epidural. And we made use of vertical positions so that she would not have to be in a horizontal position, which might slow down labor if that was the only position that was being used. So this person is entirely, she's 100% vertical. She is not reclined at all. I believe we've heard this position called the throne position, and it's used in a hospital bed where the bed is adjusted to allow for a seated position and a 100% vertical position. There are quite a few other upright positions that can also be used with epidurals. And this is something that, again, a person in labor can request. A doula can be helpful with this, and becoming educated about vertical positions in labor can be very helpful. So again, for cesarean prevention, we want to use vertical positions, not just horizontal positions. A doula can be helpful because sometimes hospital personnel may not be as familiar with those vertical positions. However, most doctors, nurses, and midwives will have at least some familiarity with it, with these positions. So there may be some advocacy that you need to do to receive help in using a variety of positions. And then the last thing I'm going to mention is an approach called laboring down the baby. That's a clinical term, and what it refers to is that once a person's cervix has fully dilated in labor, that means we're getting close to the phase of labor near the end of the process where the baby is going to be born. And many of our healthcare providers, doctors, nurses, and sometimes midwives, many of them have been trained to tell the pregnant person to start pushing when simply because the cervix has fully opened. However, some babies will not have finished making their rotation into that ideal position of the baby's back being toward the front of the pregnant abdomen. Some babies need more time to finish rotating. So just because the cervix is fully dilated does not mean that it's necessarily time for every mother to start pushing the baby out. And what we can do is we can incorporate a waiting period. If we know that the cervix is fully dilated, instead of saying, okay, let's start pushing now, we can incorporate a waiting period with no without adding any additional force to the sensations that someone's feeling by telling them to push and bear down. We can just wait. Usually that waiting period is 1 to 2 hours. And the research shows us that simply by incorporating that waiting period, known as laboring down the baby, this has been proven to be a cesarean prevention technique, so that babies who need the extra time to finish rotating will come out vaginally. And I'm going to turn it over to Carrie. And actually, you know what? Before I do that, what I'd like to do is take a micro break. We're about 2/3 of the way through, and we're going to be finishing up in the next half hour. I just want to give people a micro break of 1 or 2 minutes. We're going to pause, and I'll let you get up and stretch or use the bathroom, and come right back, and we will continue after that.
We're going to pick up now talking about our third type of labor, which is labor that starts spontaneously on its own. And this type of labor could transition into either a birth with or without an epidural. But you are likely, if you have a labor that starts spontaneously, to be in your own home when labor starts or someplace familiar to you. If early labor is long, sometimes people will engage in normal activities such as visiting friends or going out to dinner. I remember attending a movie night with some friends while I was in labor with my second daughter. This kind of social support can have a positive effect on labor. It promotes relaxation. It promotes the production of oxytocin and helps you pass the time so that labor does not become boring and stressful. You will have freedom of movement with no medical equipment attached to you, and you can walk around your house and anywhere outdoors. I had a question of what is this third type of labor called? This is spontaneous labor that starts spontaneously on its own, or you might hear it also called just spontaneous labor. So you have a lot of freedom of movement. Again, you may walk around outside. People often really enjoy a walk in the earlier parts of labor, both for relaxation and also the promotion of the good labor hormones. Movement also tends to help baby make all those twists and turns that Ananda mentioned earlier. It's normal for the progress of spontaneous labor to ebb and flow. We kind of imagine labor just kind of going up consistently, but that's not always the case. Sometimes things quiet down for a little while, sometimes they plateau for a bit, and this can be great. It can be a great opportunity for you to rest and sleep for a few hours during the course of your labor. What are the benefits of spontaneous labor? What are some reasons people might choose spontaneous labor? Sometimes you don't get to choose, it just happens because it's spontaneous. But sometimes we're presented with a choice of whether to induce, which we'll talk about in a moment, or to move ahead and wait for spontaneous labor. So in that case, it is a choice. If there's not a medical emergency, many people prefer to let labor start on its own and avoid the side effects of induction with medication. Normally, labor is started by the baby. The baby sends out hormones when it's ready to be born to the pregnant person, when the baby's lungs and organ systems have developed to the optimal point for life outside the womb, and then spontaneous labor begins. It's less likely than an induced labor to lead to a cesarean. And if spontaneous labor, again, is expected in someone's culture, this is probably the type of birth they would choose, just like with our other types of birth. And Ananda's going to talk to us a bit more about the risks associated with spontaneous labor.
Okay, so in some scenarios, a medical problem or emergency emerges or comes up for the pregnant person, and induction of labor can be used to cure certain types of medical problems, and they cure the problem by delivering the baby. So some examples that we can use of those situations are preeclampsia, which is a blood pressure problem that can become serious. It's rare, but something that, in order to be cured, often sometimes needs to make use of induction of labor. Another scenario that comes to mind is something called placental abruption, which is when the placenta starts to come away from the uterus before the baby is born. And we'll use those examples, and that might come up later in our workshop as well. And again, these are more rare complications, but the way to resolve them is to get labor started and to give birth to the baby, so that they don't, so that those conditions don't result in a poor outcome for the pregnant person or the baby. And if there is no medical problem, then the act of going into spontaneous labor is not risky on its own. However, if a doctor or midwife proposes an induction for non-emergency reasons, there's the risk that it can feel stressful for a family to decline or negotiate this. So there's kind of I'll call that a psychological risk, making a choice that is different from what a healthcare provider proposes. And it's a bit complicated, and we're going to take a moment to explore this. The current rate of induction of labor is very high, and it is the highest that it has ever been in history, in fact. So it's estimated that 40 to 50% of first-time babies, first-time labors are artificially induced. The most common reason for induction is simply that the pregnancy has gone past the estimated due date. There are studies which have found that the rate of stillbirth might increase a small amount by about 1 out of 1,000 babies after 41 weeks of pregnancies. And these are the studies that doctors in the United States currently rely on. However, the studies are very complex to interpret, and there has also been some criticism of these studies. And by applying medical induction of labor to so many people, 40 to 50% of first-time parents, there are risks to induction itself, which have now been introduced into these pregnancies. One of the resources on this topic comes from an organization called Evidence-Based Birth. They have created a document called Evidence on Inducing for Due Dates, and that's a document you can access for free. So we'll make that available to you, that link, in our chat box. The document on evidence for inducing for due dates was written by Rebecca Decker, who holds a doctorate in nursing, and she's written this paper for lay people to read. So it's not difficult to read, but it's quite long, and that reflects the complexity of this topic. So it is possible to become more informed and to have conversations with your healthcare provider about this. And now what I'd like to do is go ahead to the type of birth number 4, which is artificial or medical induction of labor. And we'll talk about what this looks and feels like. The pregnant person will start their labor in the hospital rather than at home. And to induce labor, the person may be given oral medication or a medication that is placed inside the vagina, such as misoprostol is the name of one of those types of medications, or they might receive medication through an IV into their bloodstream, which is the medication Pitocin that we've mentioned. Another technique for induction of labor is that the person might be offered a medical device that's placed inside of their cervix to mechanically open it, and that's often called a Foley catheter. And so in terms of what labor looks and feels like, just like a spontaneous labor, the early phase of labor may be long. It can be a multi-day process. So induction of labor is not like flipping on a light switch. Just like spontaneous labor, it can take a full 24 to 48 hours to get into a labor pattern that puts somebody either in early labor or closer to more active labor and the middle of their birth experience. It's very good idea to plan ahead. If someone knows they're going to have an induction of labor, plan ahead with lots of ways to pass the time. So you can bring your movie watch list, bring books and magazines, board games. We've seen sometimes people have bring in their own massage therapist or an acupuncturist to join them in the hospital and give them a treatment. And I haven't seen that very often, but you're looking for ways to break up the time and the hours of waiting where you're in one hospital room rather than moving about your own home in early labor. And as Carrie mentioned earlier, in terms of how things feel, people tend to report that contractions feel stronger than they do with natural labor. Something I'd like to mention here is that several studies have come out showing that if the medication Pitocin is being used for an induction, that's the one that is delivered into an IV or through an IV into the bloodstream. There have been a number of studies showing that when Pitocin is used, and an approach can be taken where that medication, the delivery of that medication, can possibly be turned off once labor gets going into an active state. We don't necessarily see that approach taken very commonly. However, there's no risk to turning it off and on. It has a very short half-life. We can turn it off. It can be turned back on again. And what was found in the first study I was aware of came out in 2012, but then a number of other studies were done which came to the same conclusion. And what they found is that if Pitocin is used, delivered, and then once active labor is established, it can be turned off and the person's body will take over the feedback loop of their natural oxytocin creating contractions. The studies found that what they were concerned with was if the Pitocin was turned off during an induction, would labor just stop, and then the only other choice would be birth by cesarean. And what the studies found was that was not the case. It did not increase the cesarean rate to turn off the Pitocin. So we've just shared a link to the kind of the review of the medical literature showing that that's something that a person could talk to their care provider about. Again, it's not the commonly used approach, but when people have taken this approach, this is something I've witnessed quite a few times as a doula. When they've made the request to turn off the Pitocin, it's very likely that labor will continue on its own, and that extra intensity of the sensation of contractions will come back into a more normal range rather than the elevated contraction strength that happens with Pitocin. And I will pass this on to Carrie.
There was one question in the chat when we were talking about the reasons given for induction of labor relating to stillbirth. So this one says, are the chances of stillbirth higher if going past 40 weeks? I have some thoughts about that, but Ananda, I don't know if you would like to respond to that at all.
Yeah, Carrie, why don't you start and I can add if
Sure.
necessary.
I think that the article that we've linked to from Evidence-Based Birth is a really great resource to look at for that. The kind of short answer is that the studies that Ananda mentioned, they do show slight increases. They tend to look at the period between about 37 and 42 weeks, and they show starting at 37 weeks, the chances of stillbirth are somewhere around 0.1 out of 1,000 births, and it does increase over time. The chances are still quite low at 40 weeks. We definitely encourage you to read articles like this one on evidence-based birth, talk to your medical providers and any support people like doulas that you may have to really find the actual risk. Sometimes we're just told the risk goes up. How much does the risk go up? And we can't ever decide for you. Your medical staff can't decide for you. Your doulas can't decide for you how much risk is too much risk for you. So I think knowing what the actual numbers are can be a really great way to help you decide, does it feel like too much risk for you or not? And we, as we talk about the risks and benefits of artificial induction, just kind of keeping those things in mind and playing them against the risks and benefits of waiting. And Ananda, if you want to add anything to that.
I think that's very helpful for now, and a little bit more information will come up as we talk about induction of labor as a type, a method of delivery.
Which we are now going to talk about a little bit more, the benefits and the risks associated with artificially inducing labor. And I apologize, I lost my place for a second. If there are certain types of medical emergencies, for example, as we mentioned earlier, preeclampsia or placental abruption, research shows that delivering the baby will cure these conditions. So that is the number one beneficial use of artificial induction of labor when there is a true medical need for it. Some people report that planning the date of the beginning of their labor gives them a sense of control. We just want to keep in mind that induction of labor can also remove some elements of control if it leads to side effects. It's also important to remember that just because you know the day your labor is going to start, that does not mean you know the day your baby is going to be born. That can take a few more days. For many people, induction of labor is culturally expected. Again, particularly in our culture in the US, as Ananda mentioned, if 40 to 50% of your friends and family are having induced births, that could definitely shape your choices. The risks around induction of labor is that baby's lungs might not have yet reached maturity for life outside the womb. As we mentioned, when baby is ready for the outside world, they send out those hormones to trigger the beginning of labor. So there is a chance baby's lungs may not have reached full maturity, and that might increase the chances that baby will need medical assistance after birth. Induction medications can occasionally lead themselves to non-reassuring heart rate for the baby, which makes it more likely that additional interventions might be recommended. Another risk is that labor can sometimes get overstimulated by the use of induction medications. There is a very rare possibility that overstimulation can lead to a rupture of the uterus. It is a very rare side effect. Usually that overstimulation can be corrected before that's an issue, but it is risk that exists. And again, there is an increased chance of cesarean section with induced labors. And Ananda is going to talk a little bit about a question that we get very frequently about non-medical induction.
Yes, so people do inquire about whether there are ways to encourage labor to start. And a few techniques have been studied and shown to be possibly effective. One of the techniques is something known as nipple stimulation. It's been observed all over the world that if you stimulate the nipples of a pregnant person, it will bring on contractions of the uterus. So that's a really interesting topic. We're not going to go into a lot of detail, but we will include a link in our chat box to a podcast about the research on nipple stimulation as a way to encourage labor. And this link comes from the same organization we mentioned earlier called Evidence-Based Birth. So they're actually looking at the studies on that technique. Because the rate of medical induction is currently high, many people will find themselves needing to make a decision about whether to go forward with these procedures, even if it's not expected, even if it's not planned, and even if there's not a medical problem, but simply because the numbers are so high, we'd like everybody to be prepared to potentially have that conversation with your care providers. And something that we can say is that if you are not facing a medical emergency, we hope that it's helpful to remind people that there's more than a 99.8% chance of having a live and healthy baby, whichever decision a family makes, whether that's for spontaneous labor or for induction of labor. The chances of having a healthy baby are very, very high with either decision. And something that we wish we could do is take away the pressure that so many families have come to feel about this topic just because of the current standard of care in obstetrical practice, which has changed dramatically over the years. It will change dramatically again. We can pretty much promise that every 10 years there are changes in medical practice, and we just wish we could take away the pressure that people feel. So the fifth type of birth that we're going to talk about is birth by cesarean section. And it can be, it might be a bit hard to imagine yourself in this situation if it is not your plan. However, any of us might give birth by cesarean section. And for that reason, we encourage everyone to become informed about it. Being informed about cesarean birth, it may help you with cesarean prevention. So being informed. Sometimes we hear from people who say, well, I saw that there was some information available about that in the pregnancy books that I was reading, but I skipped that chapter because I was not planning to have a cesarean section. But making use of that information might actually help somebody with cesarean prevention if that's their goal, or it might help someone be prepared in case of the unexpected. Having the information will not cause a cesarean to happen. So we do encourage people to be informed. One resource that's helpful is a book called the Mayo Clinic Guide to a Healthy Pregnancy. That has a pretty straightforward description of what happens during the procedure of a cesarean section. And so again, just that pretty neutral description of what would happen in that situation it can be helpful for people to have that information. But I'll describe a little bit about what it looks and feels like to give birth by cesarean section. First, we can think about the environment of an operating room. And this type of environment is brightly lit so that doctors can see what they're doing in order to perform surgery. The air temperature is fairly cold, in order, which it needs to be in order to inhibit the growth of bacteria. In an operating room, it needs to be cold. The rooms can look and feel sterile because they literally need to be sterile for safety when surgery is being performed. There may be some things that a person could do to make that environment feel a bit less sterile. So a pregnant person may want to bring their own music into the environment to make it a more personal feeling and to create a relaxation effect. So that's a very simple request that somebody might choose to make. I'd like to listen to my own music if surgery becomes necessary. Normally, the partner or a support person is allowed to be present. It might be one support person. Occasionally, a second support person is also allowed to be present. So that could be a doula. It's very, very helpful to have the support of a doula during cesarean surgery. However, it's at the discretion of the medical team, and sometimes a doula is permitted, and sometimes they are not. There's a preparation time at the beginning of the surgery, which takes about 15 to 20 minutes. And after that, the time that it takes to begin the surgery and deliver the baby is fairly short. The delivery of the baby takes approximately 10 minutes. A longer period of time is needed after the birth of the baby in order to repair and stitch the layers of the uterus and the abdomen. And so that part of the procedure probably will take about another full hour after the baby's been born. The baby will be examined by nurses and doctors on a warming table. And if the baby is healthy and stable, then a nurse will bring the baby to the parents. And that's a very basic description of what happens. And for more information, we like to recommend a video, which is only 12 minutes long. It's called The Natural Cesarean. And it was recorded at a hospital in the UK, which was the first to introduce certain techniques to make the experience of a cesarean section a more personal one and not strictly a medical procedure without regard to the family's feelings and personal experience. So when they say natural cesarean, that's the title of the video, but the cesarean procedure itself is not that different. But there are some other approaches that are taken to personalize the birth experience. And so a cesarean birth is shown in this video very briefly. Most of it is people talking about their experiences. And the main difference between the older approach to a cesarean section and this newer approach, which is called natural cesarean, or we hear it called family-centered cesarean, the difference between that and the older approach, the main difference is that the baby is kept in the operating room with the family after the birth, rather than a medical provider, usually a nurse, taking the baby out of the room to a nursery. So that was the older method. It's becoming much more common for the baby to remain with the parents, but it would be great for everyone to ask your doctor or midwife in case of cesarean section, can the baby remain with us? It's a reasonable request, even if it's not yet the common approach at your hospital. That's a request that can definitely be made. And I will pass it to Carrie. And I'll actually, before I pass it to Carrie, I'm going to say that we might go overtime by about 5 minutes. So if you have any questions you'd like to jot down and put in our chat box right now, let us know. And then otherwise, we hope you can stay with us for an extra 5 minutes or so.
So we want to talk a little bit about the benefits and reasons that folks might choose a cesarean birth. If there is a medical condition such as preeclampsia or placental abruption, sometimes we know vaginal birth is very possible, but sometimes the only way to prevent the medical condition from escalating to an emergency is for the baby to be born very quickly through a cesarean. If the baby is in a rare and unusual position in the womb, for example, if the baby's shoulder is trying to come out first, vaginal birth will not be possible and a cesarean would be required. There may not be an emergency, such as in the case of labor dystocia, that just slow labor. And here's where provider preference may come into effect. And the provider may not offer the family other options. It doesn't mean that there aren't other options. It just doesn't necessarily get presented because it's not the provider's go-to, it's not their preference. Unfortunately, in these cases, sometimes the family reports that they felt pressured into accepting the surgery. So that's a place where lots of questions and advocacy can be very helpful to help decide if the cesarean is the right choice. Some people choose a cesarean, again, as we've talked about so many times, because it's expected in their culture. For example, in Brazil, cesarean rates are 55 to 85% of births, depending on the area and the hospitals. So it is a huge cultural expectation there, and similarly in other parts of the world. So that can be a big part of why folks choose that type of a birth. Ananda's going to talk to us about some of the risks and side effects.
Yeah, so probably the most common side effect of a cesarean birth is the risk of infection to the uterus. That is something that might happen fairly quickly after the procedure, or it might emerge after the person has gone home. It can be treated, but if there's pain in the incision, you want to report that to your healthcare providers, and they'll let you know what the other signs are of a potential infection of the uterus. A less common side effect is an increased risk of hemorrhage or heavy blood loss that can happen with a cesarean. We don't see this happening commonly, but if it were to happen, then measures would need to be taken to stop that extra heavy blood loss from surgery. Also not very common, but a possible risk is that for future pregnancies, the placenta might grow into the uterus and into that scar in an abnormal way. Not a common side effect, but that is a possible risk. And recovering from surgery is often described as more difficult than recovering from vaginal birth during the postpartum period. And so what expectant parents might want to do is think about, what if this unexpected scenario were to happen? How would we get extra help and support during the postpartum period? Because if we'd love for people to have a plan that in case of the unexpected, who would you turn to for additional support, and have those conversations with them before your baby arrives. So it might be that, a family member is coming to visit 2 weeks after the birth of the baby, but in case of an unexpected scenario, could that person come sooner? And in most cases, the answer is yes, but these conversations are really helpful to have. And the last possible risk I'll mention right here is that with any surgery, there is an increased, there's a risk of depression after the procedure, and doctors might be more likely to mention that to people having other types of surgery. They sometimes forget to mention it to people who've had a cesarean section. So we want to be on the lookout for increased risk of postpartum depression after a cesarean section. I'd like to recommend an article on cesarean preparation and recovery by a wonderful doula named Diana Snyder, who used to be here with us in the Boston area. She's moved away, but she's a doula as well as an attorney and a birth advocate, and she's done incredible things for parents and people who are pregnant. And she created an article with tips on cesarean recovery And there's a lot that you can learn about how to make this more complicated type of recovery into a gentler experience. So whether or not a cesarean is part of someone's plan, we'd love to recommend that everybody read this article in advance so that you possess the information in case you need it. And we've placed that into the chat box. And we are just about to finish up here. And what we'd like to say is that whatever type of birth you are hoping for and whatever type of birth you experience, we encourage you to do a few things. One is to become as informed as you can be. For those of you who are watching us live, you can save the chat here on Zoom. And you can save all of the web links and books that were mentioned in class. And we hope you'll explore those more thoroughly. As doulas, we really believe in being informed, and we're so glad that you are watching. Number two, we encourage people to talk to your doctor or your midwife about their approach to helping you have the type of birth you are seeking. So that's literally the question you can ask your doctor or midwife. You know, if I were to say, I'd like to, I see myself giving birth and making use of an epidural, but I would like to prevent a cesarean section. What is your approach to helping me have that type of birth? And that is an excellent conversation to have. And then number three, we encourage people to bring an advocate when you give birth, whether that's a doula or somebody else, a friend or a relative. It can be a friend or a relative who you feel confident knows how to be a good support person for you. Even for if you're partnered, we recommend having an additional person there who can gently serve as your advocate so that you, as the expectant parents, do not have to think about advocacy by yourself the entire time. And you can continue to have those conversations. So before labor happens and in the middle of birth itself, we want to see people having the most informative conversations that they can have. So we are going to officially end our program here.